Okay, let me turn to today's activity. Alissa Jordan, as most of you know, is a multimodal cultural anthropologist who received her Ph.D. from the University of Florida in 2016. Her research focuses on questions of bodily being, bodily security, and creativity across field sites of rural Haiti, Ghana, and in social spaces in virtual and augmented reality. Alissa investigates these questions using methods of experimental writing, collaborative nonlinear filmmaking, sensory mapping, photography, museum exhibition, and digital experimentations. And I should say she's also recently released a podcast on the work that she's going to discuss today, which is really fantastic. So today she is going to discuss current research on women's experiences of birthing and care as resistance in the context of hospitals that imprison mothers, infants, and other patients for death. She is joined today by her collaborator, Carmelle Moise, who is a midwife and board member of the organization MamaBaby Haiti. And I will let Alissa introduce Carmelle more fully now. And welcome.
Thank you very much. Okay, great. I might go ahead and speak while Carmelle gets reconnected. Carmelle, are you here with us? Can you hear me? She jumped in and out. Okay, so Carmelle Moise is going to be joining us, and when she gets here, there's some issues with the internet, but I was gonna go first anyway, so I'm gonna go first, and then Carmelle will come in and speak about her role in all this project. And actually, my little talk that I'm just gonna give for 10 minutes is gonna introduce the work that I've done with Carmelle. Carmelle Moise is a fantastic midwife at MamaBaby Haiti, which is an organization that runs 2 birth centers and a midwife training school in Haiti. She's also a member of the board at MamaBaby Haiti, and her work there is fantastic. It's devoted to helping women. It's devoted to helping women give birth and helping families and birthing people give birth in safe, affordable ways and in just ways. And as a result of that, her work comes into contact a lot with the interface between traditional midwifery and the hospital and biomedical system in Haiti. So she has done a tremendous amount of work, really is a pioneer in doing work on hospital detention in Haiti. And it's because of her work that I came into this project, and I will talk a little bit more about that now. I also want to mention that we're joined here by Michel Pierre Saint-Phar, who will be translating for Carmelle when she comes in. And I've worked with him on other projects related to this, and he's also been closely involved in the research throughout. So without further ado, let me just explain a little bit about the research. This project actually started because of a post that was forwarded to me, or my involvement in the project started because of a post that was forwarded to me by a birth activist that was about hospital detention. And it was tied to fundraising that an organization was doing to gather hospital fees to pay for the release of mothers in northern Haiti. And an American volunteer had commented on the post saying, only Haitians in Haiti would do this to each other. And there are obviously a lot of problems with that attitude, and it has a long history in European narratives about Haiti's exceptionalism. And in this case, the exceptionalism was doing a particular kind of work in keeping this problem isolated, disconnected, and seen as non-systemic across the places where it happens. So keep that in mind as I go on with the rest of the story. As to that particular comment on that post, I wrote back a comment to that commenter, and then I reached out to the organization who had the post, MamaBaby Haiti. And so they're not the ones who wrote the comment, they're just the organization that had the post. And I wanted to, my hackles were up when I read about mothers being imprisoned. I thought there was something very strange going on in terms of, what was happening to these mothers, to other patients that this was happening to, whether or not it was true. There were a lot of questions swimming in my head at that time. So I reached out for some clarity. I was especially concerned in rectifying the fact that Haiti was getting blamed, at least on some of the commentators, so not the organization itself, but the commentators, because the hospital in question that was being mentioned was actually 100% funded and tightly operated and controlled by an American hospital group that was connected to a large American mission hospital in New Jersey. And they were famous for taking large teams of medical doctors and volunteers from the US to the hospital all year round. And had received good international press as a result of that. And yes, it turns out that they were imprisoning mothers for receiving that care afterwards. So I didn't know the extent of the issue or the experience of the issue at this point, although my work had largely been done in how mothers and ritual healers, especially women ritual healers, manage birth at home, which is where 72% of births happen in Haiti, and how they deal with the postpartum period at home. So I didn't know about the extent of the issue, but I wanted to understand more. When I got in touch with MamaBaby Haiti, who I've introduced already, I got connected to Carmelle, because one of the midwives at MamaBaby Haiti said this is really coming out of Carmelle's activism, out of Carmelle's project as a very socially invested midwife, so you need to speak to her. And I got connected to Carmelle, luckily, at that point. And I asked if there was anything I could do to be helpful. And it really seemed to me at that point that it was because of this mission hospital and then another mission hospital in the area. And the project just kind of exploded out of that, especially when Jean-Denis Sorgelius, who is a human rights advocate out of ADEF Haiti, ended up getting involved in the project a little bit later on. And he started doing work looking at hospitals in the South and Western regions. At the same time, China Tolliver was a birth activist, who's a birth activist and photojournalist who co-hosted the first audio documentary with me, was doing work in the north of Haiti. So in that first call with Carmelle, this WhatsApp call that I had with her, or that first day, actually, it wasn't the first call. So it was in that first day, she explained to me, Milot is now holding at least 9 women captive. The mothers were trying to keep the newborn babies out of the rain, but that they were locked in an exposed patio. And the Baptist hospital, she said, was holding 4 women, 1 mother whose baby had died, and she had been locked in a storage room, the mother, for a series of months. The American hospital worker, this is Carmelle explained to me that when she went to one of these hospitals, an American hospital worker came out to her to explain that that's how they run their mission and that the mother will be set free when her family paid the bills. So I started contacting these mission hospitals from the American side of things. And when they wouldn't release the mother, I started trying to contact everyone associated with the mission hospitals that I could find. Meanwhile, Jean-Denis and Carmelle, who were doing all this on the ground work, Carmelle in the north and Jean-Daniel in the central and western and southern areas, I remember Carmelle and Jean-Daniel saying, as this project went on, from both the different places, it's everywhere. It's just happening everywhere in every mission hospital that we go to. And I don't think at this point, that wasn't shocking for them to say. It's not like it was, they were realizing the extent of it. They were trying to communicate to me the extent of the problem. So I was combing through websites, social media, and publicly available tax documents at this time to find board members' names and contacts for any hospital where I was getting told that there were mothers and other patients being held. And Carmelle and Jean-Daniel were out finding patients or families of patients who were currently imprisoned. And it became clear that not only was it happening at an extraordinary number of well-funded, internationally lauded, human dignity-centered mission hospitals, but that they would openly admit to that on the phone. They didn't have a problem talking about it. And I also want to be clear here that this is not, that although I'm talking about these mission hospitals, that Partners in Health is completely outside of this. Their hospital does not participate in hospital imprisonment, and they have policies to that effect to prevent it from ever happening. The other hospitals that would speak to it about on the phone didn't call it hospital imprisonment or detention. They would just refer to it as holding people, because to let them go would be allowing them to steal what the hospital had invested in them. So, for example, one American medical missionary from a hospital in the south of Haiti explained that it specifically wasn't imprisonment, that what was happening is that the patient would be stealing their own body if they left. As it happens, over the past 30 years, the practice of hospital detention has been effectively institutionalized in global health systems and wedded to the delivery of Western obstetric care in a tremendous number of nations across the world. Anyone, any patient can held this way. But the world over, it most commonly affects pregnant people, and most especially pregnant people of color, by a margin on something of 4 cases of women being held for obstetric care to 1 case for any other reason. Cash poor birthing people thus face this dual reality of hospitals, both as places of care and places of captivity. A recent research article in the International Journal of Health Policy Management, for example, identifies the practice in over 52 countries, but Chatham House estimates that number to be higher. And I should mention that in all those cases, Haiti didn't even make the lists. So there are plenty of countries where it happens, where it's simply not been spoken about to the extent that it is in other countries. It's a ubiquitous feature of obstetric care in cash poor countries. And though it's widely illegal in those countries, it's rarely challenged. Patients get imprisoned in hospitals after these hospitals extend life-saving care. And given that that life-saving care is often the most expensive care, it becomes this enormous credit as the hospitals see it. Then, acting both as bodily caregivers and bodily creditors, hospitals impound patients, treating them as a form of security that they can hold until the debt is settled. And I want to credit here the work of Kakuji Yumba Pascal, who's a bioethicist and legal historian. He's a professor of rights at the University of Lubumbashi and the chair of the Department of Private and Judicial Law. And in one of the very few number of academic articles that are written on the practice, he analyzed the process of forcible confinement in a maternity ward at Jason Sendwe Hospital in the Democratic Republic of Congo. And he looked at it in a really fascinating way as part of legal history and bioethical history. His work discusses the way that hospital detention presumes or even enforces a credit lending relationship where a creditor has a tangible connection to or tangible interest in the actual body of the debtor. Because of that tie, from the perspective of hospital creditors, patients' bodies can be sequestered, they can be repossessed, they can be held as collateral security to enforce debt repayment. The bodiliness of debt that underlies that logic actually appears in the ancient Roman world. And this is part of the historical work that Pascal did, which is really tremendous. He connects it to a legal procedure known as manius in iecto, or the laying on of hands. This procedure allowed creditors to forcibly sequester debtors upon their own property for 60 days, during which time the debtor or the third party could pay back, well, not the debtor, but the third party, specifically their family, could pay back the debt in order to release them. After 60 days, the creditor could effectively liquidate his insolvent debtor by selling them into slavery. And that's mostly what happened. In other words, the debtor was linked to the creditor much the same way as any other asset. Where hospital detention is practiced, which is in a tremendous swath of the globe, it relies on the same dependence on family and community as manius in iecto did. It deliberately exerts institutional pressure on kin ties by putting the body of the debtor through hell, through a really undesirable situation, then of course threatening that they will never see them again. The practice forces families and communities to ransom loved ones, and in that way to weigh the loved one's value against the kind of predatory loans that they have to take out in order to free them. So in hospital detention or hospital prison, mothers and other patients are sequestered and held as debt, usually in separate holding areas than other patients, in wards and hallways or in outdoor sites, and they're guarded to prevent escape with institutional workflows in place that control who gets to leave the hospital through receipt and extensive stamping systems. Usually that's what happens in Haiti. And that process of determining who leaves the hospital is often much more intensive than guarding who comes in the hospital. In spite of its ubiquity, the widespread global postpartum imprisonment of Black and Indigenous women and women of color, there's no peer-reviewed research on hospital detention in anthropological literature to date. The International Journal of Health Policy Medicine and Rob Yates's report at Chatham House draw from media reports on the practice, that is local journalists' accounts, rather than direct research. And that's because there is little published research on the practice. And like I've said, very, very little anthropology. These silences seem particularly resounding to me. That's part of what drew me into the project, aside from the you know, the more clear you know, just the nature of it, which I think is compelling, or hope that you guys will agree. And in the face of accounts by local journalists the world over, of which there are so many, I think last time I spoke to Rob Yates, he had something like 3,000 or 5,000 that he had put together of media reports on the practice. So those silences, these academic silences, were particularly compelling to me. I'd also like to credit here AP journalist and senior health editor Maria Chang, who's done tremendous on-the-ground work on hospital detention. She's worked to link it to myriad international funding pressures that exist, and she's interviewed detained patients and hospital administrators in Kenya, Congo, Slovakia, Bolivia, Malaysia, and the Philippines. Her work is especially important in calling attention to the discrepancy between the systemic institutional silences built around the practice at the level of global public health, compared with the matter-of-factness of clinical imprisonment of postpartum mothers and others around the world, and the ease with which hospitals were willing to speak about the practice when she went to speak to them about it. When imprisoning mothers within hospitals or impounding the bodies of those who die, which is a practice that's connected to this, hospitals entangle medical care and carceral strategies as institutionally compatible approaches that create value, assign debt, and extract capital from patients' bodies, especially women's bodies, and most especially the bodies of Black, Indigenous, and people of color, and their reproductive bodies. That comes out of a long history. A common argument that I have heard from hospital administrators is that the only viable public health alternative to imprisoning mothers after surgery is to refuse them treatment at all. Something that's also familiar to mothers in Haiti's health systems and many health systems outside of Haiti. And it's that choice between medical violence and total abandonment that's not unique to hospital detention. It's part of what Julia Chinyere-Opara and Black Women Birthing Justice refer to as a system of global obstetric apartheid. It's an impossible choice between, as Opara puts it, coercion and malign neglect. Hospital prison thus follows out of a long-lived historical entanglement between race, capitalism, obstetric medicine, and carceral strategies. That entanglement undergirds the institutional logic that makes it possible for administrators, medical volunteers, and Christian charities to insist that they have a duty, a calling even, to save poor Haitian mothers' lives, but that duty requires stripping them and their babies of basic freedom. It's the same logic that insists that at a public health level, that Haitian mothers and babies must be rescued from the perils of home birth out of respect for their lives, but that this respect requires transforming those lives into collateral property that can be instantaneously repossessed. Yet, it's important to mention, and I really wanted Carmelle here to speak about this, that these injustices do not occur unchallenged. In Haiti, mothers, families, organizers, and birth workers have been raising flags about the practice for a while, and Carmelle in particular has been active in the fight against it. Haitian medical workers themselves are also important critics of the practice, such as a nurse who was in the audio documentary that I produced, and very importantly, some hospital guards who've been really invested in moving the project forward, given they're frustrated and active against the indignity, but they don't have the same capability to resist without immediate threat to their lives and that of their families. So community leaders throughout Haiti periodically also work to address the issue on a local level by negotiating with hospitals for the release of patients. And that's something that's pretty common around the globe where this happens, is that you have certain community leaders or politicians who can negotiate prices and at certain points of the year release a number of patients at a time. Within hospitals, Haitian mothers confined together often also serve as the most important allies for one another. They share food, cell phones, and conversation. And those kinships, I think, are really important, especially given that they occur in the face of intense coercion, where this surgical attention that they've been given to save their lives is financially supported through really strategic neglect. And it's a place where emergency credit instantaneously becomes bodily debt, and a space where the very notion of one's body and one's life being indebted, being a security or an artifact of debt, is discussed and resisted by these mothers and their families. So Hospital prison is not simply a site where Haitian women's lives and bodies are taken up or hooked by social, political, and capital forces, but it's also a vital site of direct action against those forces. The project that I've engaged in so far, which is largely, a lot of it is activist, but we've done some really good audio documentary or podcasts, one in English, one in Creole, with a lot of supplements with some of the people I've mentioned here today. But it's also had to teach me a lot about remote collaboration because it's been done remotely, given our current dispensation with COVID. I think remote work is important. I think that it's not easy. It's not always great. I don't have some hugely optimistic takeaway from it, but it's possible and there are important benefits. And also in the tradition of a work in progress, I just wanted to say that now that I've kind of introduced the project, what we're working on right now with Carmelle and Jean-Denis, as well as the nurse who's in the audio documentary, is how to build a solid project around this topic, something that we're calling, for lack of a better word, a report on hospital detention in Haiti. And we're doing this by gathering oral histories from mothers, families, and hospital guards in each of Haiti's regions in order to produce an ex-patient-centered archive of experiences of detention and of visions of justice and birth justice and imaginings of different forms of birth care, one that's written, visual, and oral. And then we're going to gather together the transcribed stories and publish a national overview of hospital detention in Haitian hospitals, which will be the first national report on debt-based clinical imprisonment in Haiti, but one that we're really hoping to use as a pilot for archiving and attending to this practice and to women's experiences in other countries. So thank you. That's my portion. Now what I would love to do is introduce Carmelle, if her audio.
Is she iPhone or is she one
Yes.
of the numbers? She's iPhone?
She should be iPhone, yes. Let me
ask to unmute. Also, Alissa, I was wondering if you'd be willing to put the link to the podcast in the chat.
Definitely.
So that people could listen to them after.
Definitely.
So I'm asking to unmute, but I'm not sure.
And they might be, maybe she's been texting throughout. So sorry about this hiccup. Carmelle was on the phone with us earlier, but got caught up on the road in a protest in the north of Haiti because she's calling in from Haiti. So perhaps it would be good now if we can just, I'm texting her right now on the phone, but if anyone has any questions, or maybe we could just move on to a short question period.
But yeah, why don't we see if people have questions? And it's informal, so you could just go ahead and unmute yourself and ask the question. If you prefer to post it in the chat, you can do that also, but I'm sure we'd like to see you.
Hey, Alissa.
Hi.
Go ahead, Grace.
Question. So the same way that the organizations gather funding for the procedures that they assist, the initial procedure they assist the mothers with, why not extend the gathering of funds to the paying off of the debts? Like, what's the difference? What's the rationale for being able to try to gather funds, or get people, to fund this part, but not the other part? Like, how do they rationalize that?
That's a great question, Grace. There are a lot of different answers to that. And thank you for that question, because I feel like that's a core part of what, that's a core part of where the struggle's at. So the biggest, broadest answer that I feel like is applicable to the most situations is that the way that a lot of funding is that a lot of funding, especially health funding, operates in Haiti, where 46% of the health funding comes from international dollars, not from local or state governments, not from people themselves. Is that there are a lot of politics of international funding where individual donors have a lot of have a lot of control over how their funds get used. So at one hand, there's the problem of large funders who have a great deal of control over how those funds get used, and many of them explicitly forbid the use of funding to support day-to-day practices. Instead, they tend to go towards big machines, towards new wards, towards other aspects of the hospital, and they don't tend to support electricity or, especially in the case of hospital detention, salaries. So that's one answer. That's an answer. I feel like that's that leaves a little bit of the reality out. The reality that I would speak of is I really want to pinpoint the kinds of moral judgments that get made in these spaces, and the importance of the fact that even though there may be money, or there could be money to focus on not having women imprisoned after birth, that the reality is a lot of the administrators that I've spoken to have openly expressed an attitude that I think is prevalent in aid structures across Haiti, that it's quote unquote not a handout, it's a hand up. That the idea of getting free hospital care, the idea of simply letting people walk away with free medical care is not acceptable to a lot of the organizational people that I've spoken to. So I've given you one institutional response. So I think institutions respond in a second response that I think speaks more to the truth of the importance of the moral economy in Haitian healthcare and aid structures in general. And I would say too, to second that, to clarify, at most of these hospitals, there are exoneration funds that exist specifically in cases for patients that cannot afford to pay. Those exoneration funds are rarely accessed. Because of the kinds of judgments that have to get made about who is truly poor enough. So there is a complex negotiation of judging whether a woman really has money that she's hiding, or perhaps a reluctance to draw from fund that's limited, et cetera. So in many cases, the idea that this is simply a problem where there's no cash to support the release of these women is blanketly untrue. There is cash, often at the same hospitals, often within the same administrations, to release it, and there's a lack of desire to do so.
Alissa, I was interested.
Just one second, Carmelle. Sorry, I'm so sorry. Carmelle is calling on the phone.
Is she back?
I'm going to see if I can connect her.
Okay. In the meantime, maybe we could gather some questions or hear some responses from some of you who are here.
I'd like to talk a little bit about that situation. I think one of the problems with these mission hospitals is that they operate just like a hospital back in the States, essentially. They have a large budget, they have a lot of doctors, they have expensive staff, all of the expats that work there. I know they have a lot of volunteer groups that go there, but they probably have permanent staff too. And I think this is a big reason why it's better to invest in grassroots operations. And I'm speaking specifically about midwifery centers because the overhead is extremely low. I'm not trying to blow my horn here, but our organization operates a midwifery center in Torbec, outside of Lakai. When we originally opened it, all the services were free, period. It was just free. But a group of health committees from local villages came to speak with our director, in-country director, and they said, you really should be charging us a fee because we value the service that you provide, and we don't want to be dependent on charity from the US forever. And so we sat down and talked to them, and we asked them, what do you think a fair fee is? And then we adopted those fees, but on a sliding scale that starts at 0. So if a patient shows up and they don't have the money, they don't have to pay. If they have half the money, they can pay half the money. But the reality of the situation is that they set the fees at a level that they knew people could afford, and 90% of the patients who show up pay for their care. And if they don't have the money with them, they come back later and pay us. And obviously this isn't enough to fund the operation, but it's added up to between 10 to 15% of our operating costs, which is significant. I think coupled with some economic development work that we're embarking on, that's going to be a hand up. And I mean, they talk about a hand up, not a hand out. Well, they're not giving these women a hand up in any way whatsoever. So, and I'm sorry, that's all I have to say about it.
Thank you so much for that, Jim. I think too, I want to, there are some questions that are related to this. So one thing I want to bring up is the fact that most Haitians, and I would argue that this is the case for most Americans and in many countries of the world, cannot afford catastrophic life-changing expenditures on their own. So we can talk about the cost of coming into a hospital, getting seen, having traditional midwifery care. I think those are all hugely important pieces of the puzzle. But the place where what's happening when these women get imprisoned, and I have a question here about how long that happens. I was working with a woman who got imprisoned for 4 months during COVID in a hallway at one of these mission hospitals in the north. She got released in December and she'd been there for 4 months. Her bill amounted to 4,000 American dollars. That was an impossible sum. So the expenditures that are happening that are keeping women and that keep other patients imprisoned are huge. They're massive. They're not usually from a consultation. They're usually from obstetric surgery, especially cesarean sections or neonatal care of any kind. So I think it's important to note the incredibly important role that good midwifery care has in keeping and in monitoring symptoms, et cetera. But in a lot of these cases, a midwifery clinic would not be able to support a child that was born 2 months premature, and they wouldn't be able to do the emergency surgery necessary, for example, with twins going into birth early on. So in a lot of ways, I think that seeing it as it's important to see it as an economic problem. It's important to recognize the extent of the economic problem. And I think it's important to acknowledge the way that catastrophic life expenditures of all kinds are buffered in other places, that there's no buffer for it in Haiti. And I think there are systemic reasons for that. But when I think back to, I gave birth to my babies 2 months premature, and the cost of the hospital bill was in the hundreds of thousands, that because I had insurance, I didn't have to pay it. What we have is a situation where there's no insurance, where mothers go in, and where there, as I've said before, there are funds to release them and they're not getting access, at least at these mission hospitals. The situation is quite different at public hospitals, but it's also less common because the kind of medical equipment that it takes to rack up these huge bills is more prevalent at well-funded NGO hospitals.
That's all true, but I would say that the evidence shows that midwifery centers greatly reduce the incidence of cesarean section. I think because they know the techniques required to ensure that the baby can be delivered naturally. Of course, mothers do have to sometimes be referred to the hospital for a cesarean, but the rate is much, much lower than you will find in a hospital.
Yes.
I wanted to direct you, Alissa, to a couple questions in the chat. Manya Gupta has asked if you could talk more about how the negotiation to release women by community leaders takes place. What sorts of people are hospitals likely to listen to, and why? Are there people who don't get negotiated for? Who might that be? And I'm just going to tag on a little extra piece to that, which has to do with the security guards at the hospital, because listening to your podcast, I was really interested in, the role that they play in this kind of process specifically. So would you talk a little more about that?
Definitely. So the negotiation, I was hoping that Rob Yates might be here, because he's actually done, he might be here, perhaps I can't see him. He'd actually done work on this question before. And I think that Maria Cheng has also spoken about it in her own research. But in short, it's a similar story in Haiti as it is in other nations where it's been reported on, which is that you have community leaders who have particular relationships with hospitals, who may find out and are looking to garner active political support for their own cause. And in doing so, they make a gesture of goodwill, such as releasing a certain amount of patients each year. And I don't want to I don't want to minimize their efforts because they result in people getting freed sometimes. But I would point out that it's certainly part of a system that continues to sustain the practice. So when they negotiate for release, typically if you're negotiating for 8 or 10 women, you can negotiate the prices of their surgeries down because the hospital is going to get one lump sum instead of, you know, fighting for each individual sum of money that it's going to get. So that kind of negotiation happens. I don't have it's individual cases on who get negotiated for most of the time in Haiti. And it's what I've heard about in Ghana as well with Ghanaian politicians and in Congo, which is that especially these are often for the cases in which women are being held, which is the majority of hospital detention cases anyways, where you have like 9 people at one hospital and someone negotiating for them. Are there people that don't get negotiated for? I think definitely. Although the number is much smaller, there are patients who are not women, who are not pregnant, who have other situations that are particularly, that I feel like do get lost in the cracks. And I want to be attentive to that in my own work, to saying that although this really predominantly, I mean, on a huge order affects Black women and women of color and birthing people of color across the world, you have these cases where other patients get pulled into it because of catastrophic expenditures that happened at the health level. And I'm thinking now of one case where the impact of the practice is particularly, the impact of the practice is deeply felt in cases in which someone goes into a hospital. I was working with a young boy. Carmelle could actually speak about this because she went to go speak with the boy and his family at the hospital. But a young boy had a case of sickle cell anemia, and the hospital couldn't treat him, but because of the sheer number of exams that they had done on him, they wouldn't release him. He needed absolute life-saving care at that point because he was going through a stroke, and they held him throughout that process. So there are other patients I feel like that do get lost in the cracks because in some ways it's so much more common for mothers, for this to happen to mothers who are in obstetric situations, but there are plenty of other people that it affects as well. And I think there's probably, you know, we do need to attend to that. And as to, go ahead.
No, go ahead.
I was going to say, and as to the guards, I mean, so I just really want to like tag the importance of the guards in the project, even though we can't name people obviously, and they're not here, they're not listening, but the role that guards have played, and that I believe we will continue to see guards at other hospitals play, because it's already worked out at two hospitals in a big way, that guards have been really active, hearing about the strategies that they use to negotiate, to try and get help from others, to in some ways to fundraise for them, to funnel food in, to work in different ways to release them. This is not all guards. I don't want to give a picture of this as a sunny situation, but there are certainly ways in which there are solidarities that exist that can't be fully exploited. Guards, for example, are fined the entire amount of the stay of a patient if a patient escapes. But there are people who are actively working against that in different ways and trying to stretch the system. So that's what I have to say about that. And the guards often play, especially in Carmelle. And I think I was really hoping Carmelle would connect. It looks like she hasn't been able to, but Carmelle would be able to speak about that to a greater extent, because she's really worked extensively and seen the role that the guards have played.
Yeah. Returning to the questions in the chat, Ava Vinifet, hi Ava, is asking, what is the length of time these women are being held, and what are the conditions they experience?
For the people specifically that we mentioned in the audio documentary, and the ones that Carmelle and I have gathered oral histories from, I would say that the average time is a month that people spend in detention. But nationally, I would expect that to be closer to 2 months. And yeah, that's what I would guess, is that the average is somewhere around 2 months, but it's very hard. There's no clear data on that. And it's certainly true that there are going to be cases where people have been held for a year or longer. In Kenya in particular, children can grow up for their first 5 or 6 years of life in hospital detention in pediatric centers after they've been born because of cesarean sections that people can't pay for. So it varies wildly, and it can be on the order of years. the conditions that they experience, that's what we need to listen about. I don't have the answers to all of that. I have answers for the hospitals that, for the hospitals and the mothers who've wanted to share their birth stories with Carmelle and I, and they're not, the conditions aren't great. In fact, I want to mention that the conditions that they face are would not only seem bad to a hospital worker in the United States, but that at a local level, they violate a lot of the tenets of postpartum care that are deeply important to Haitian traditional practices, Haitian traditional birth practices. So in particular, I want to mention here the importance of Ph.D, which is an experience of cold that it's a word for cold, but in effect, it's a kind of disease that can enter your body through different openings. And the way that ethnomedically, the body of a Haitian woman is constructed, and all women, according to Haitian traditional ethnomedicine, is that at birth, and I think that there's a lot of similarities here, at birth, the body opens, but women's bodies are subject to all kinds of rhythmic openings and closures. However, in the case of birth, this opening is extreme. And there are specific precautions about how she can be exposed to the exterior elements as a result of that. And in fact, it's considered in the work that I've done in Akaye and in Port-au-Prince, in Kafou, it has repeatedly shown that that next to the sudden illness of a child, this is considered next to a very particular sudden illness of a child, which I'm not going to go into detail here, but next to that, it's the #1 cause for the death of a mother and the death of a child after birth, or it's seen to be that way, which is the exposure to the elements, is the exposure to the elements, and particularly the entry of cold into the openness of the body. So the reason I'm bringing that up is because I want to talk about the ways that these conditions, that simply being outside on a concrete patio, which may not seem, perhaps that terrible, as I've had some aid workers say, these women would be giving home at birth on a dirt floor. What does it matter if they're on a concrete patio at a hospital? That there are important ways in which that hospital, in which the kinds of suffering that occurs there are particularly egregious from a perspective, from a Haitian ethnomedical perspective. But the conditions in general are, they don't have food and they don't have water unless it gets brought in by someone else. And if these mothers come from the hills or come from a place that's really far away from the mission hospitals, and their families can't afford to come down because they live 2 or 3 hours away, they go for many days without food. And that's really hard to see and to hear, and it commonly happens. And that's where guards and nurses can step in sometimes to help, and mothers especially work to feed one another.
And there's a question from Ginny Holter. Where are the nurse midwives trained? I think this came up after Jim Grant's question. What is the licensing process? How do they work with traditional lay midwives?
Great. So the nurse midwives are trained, the ones that I'm working with, like Carmelle is trained at Carmelle trains them, and Carmelle is trained herself. So that's at the MamaBaby Birth Center. There are 2 of those, and then the midwifery training school in the north of Haiti. There are several midwifery training schools. Jim Grant brought up, it sounds like Jim Grant works at a midwifery center. I don't know about there is licensing for nursing. So as a specialist nursing license that exists. But a lot of when I speak about midwifery in Arcaye, I'm not speaking about people licensed through official networks. I'm talking about traditional lay midwives. I think that Jim Grant and Carmelle would be able to speak more about the ways that these practices intersect with one another. But in general, I think there has been a decline. It's important to note just that there's been a decline in lay midwives in general, and in midwives of any kind in Haiti over the past 30 years. So recent resurgence of midwife training programs and a resurgence of interest at the local level in reinvigorating midwifery knowledge is happening right now, and it's exciting to see.
As other people put questions in the chat, I wanted to ask you how you're envisioning the kind of experimental ethnographic or the multimodal work especially in relation to this national report that you're doing. My guess is you're not submitting to the government a report that is filmic and podcasts. And so how do you see these different interventions working in different ways?
So I think that I had a conversation with Louis Messiah, which was really helpful in terms of thinking about audience in a deep way for all these different interventions. And I guess the process of having to do oral histories and having to do things in terms of audio recordings, which is what we did for the audio documentary remotely, turned my attention to the value of that as a method. So I guess in a short answer is that yes, we're not turning in a filmic video audio production to the state. That's not the goal. But what is the goal is to be able to share stories that are centered in women's experiences, and that in which they are articulating as they see it their own visions of justice, and able to feel comfortable enough in a space to do that. And so I don't know if this is exactly your question, but it's something that I'm thinking a lot about, which is originally Carmelle and I were talking a lot about doing some kind of audiovisual documentary with a camera. And we were thinking, okay, we're going to have to do this procedure of sitting people down in front of a camera, getting them comfortable with the camera. We were really excited about the possibility of having women co-direct scenes if there were going to be reenactments of their story, et cetera. And there were 7 mothers at that point who were really on board with that idea. But we were thinking, how are we going to get people comfortable with cameras? And having used cameras in Haiti before, it's a long process. So that was still very much forefront in our minds up until the audio documentary finally came out and came to be. And what I realized in that process, and I think Carmelle realized too, is that the comfort of a lot of these stories that were used in the audio documentary and the way that we're planning to do the oral histories going forward were mothers recording on their own phones or on phones of people that they knew, typically in private settings, and then sharing them remotely. So there was a great deal of distance between the moment of recording and a person actually being there in front of someone's face. And we felt that it was really powerful, that you could hear the intimacy of that experience, that there was a lot less self-consciousness in how people were speaking about what happened to them. And we felt in general that that after conversations with the mothers who were sharing these stories, that they felt that they had a great deal more control over the situation using this telephone WhatsApp methodology that we were developing. So for the report, we're not going to attach WhatsApp recordings. We're going to be transcribing the spoken histories, but we are trying to, especially with birthing resistance, www.birthingresistance.com is a website that we're building up where we will be including anonymized versions of the recording. So that's where we alter the voice so that it's non-recognizable, and we take out proper names within it for mothers who wish to have their stories shared in that way.
I see Carmelle has been able to join us.
Great.
Hi, Carmelle. Maybe you want to share with her what we've
Carmelle, bien content wow. Pardon parce que moi j'ai un problème de connexion, mais si vous voulez parler kounye là, m'a pas traduit pour parce que c'est une fois gen temps sorti, mais nous même nous déjà parlé sous problème. Nous déjà parlé sous détention de l'hôpital, moi expliquer projet à n'a fait, moi expliquer projet di maman Léo ba histoire pa yo bagay comme ça. Même quand on gen quelque bagay ou vle présenter, moi vle l'ouvrir espace pour ka faire ça puis m'a traduit pour. Okay, so I've invited Carmelle. Hello everyone.
Moi, je suis content jeudi pour nous chiter ensemble avec nous, pour nous partager la situation à passer dans l'hôpital. C'est pas seulement Haïti, mais la situation a passé tout côté là, au Québec, maman yo dans prison parce que pas capable payer.
Yes, she's very happy to be here speaking with everyone, and especially talking about the situation in Haiti. And she's also mentioning that it's not just in Haiti that this happens, that it happens in many places.
Moi, je suis senti content que nous t'ai partagé et maman yo qui te couché sous ciment, qui pas capé sur internet là, et puis madame Alissa te rejoint nous pour nous te ka ouais, nous te ka aider femmes yo sortir dans situation ça, on était vraiment content.
She's saying she was happy about the ways that we collaborated at the beginning, especially when with those first original women that I spoke about in the story, those 9 women who were lying on cement at Milo. Oui.
Et situation sont situation qui vraiment compliquée, surtout pour femmes haïtiennes nous yo. Là que yo fin faire un petit monde. Parce que sous chaque femme nous gagne, peut-être qu'à jeune nous deux qui travaillent dans le pays d'Haïti, on va garder ces moyens, vraiment, on va garder ces ressources pour yo payer quantité l'argent, là au fin faire césarienne ou bien au fin accoucher dans l'hôpital là pour payer quantité l'argent que l'hôpital là mande yo.
It's a really complicated situation in Haiti because of the sheer quantity of mothers that don't have access to resources to pay for all aspects of birth, not to mention what happens when you have a cesarean section or another grave problem that occurs.
Et si que nous devons avoir une solution pour nous être capables de retirer femmes dans la situation, ça, on pense que l'étape mieux, surtout pour femmes haïtiennes, parce que
Carmelle, vous coupez, oui?
on peut aller à l'hôpital, on peut rester là, parfois on peut mourir parce qu'il n'y a pas bien. Moi dis parce qu'on peut aller à l'hôpital parce qu'on est au final faire césarienne, on final coucher pas bien l'argent, puis on capable payer pour retourner la caille.
Right. So she's speaking about the need to come up with a better system. There need to be changes that have to get made because of just the sheer amount of people, you know, waiting. And I think she even mentioned, I didn't catch the last part of it, but she was speaking about the way that there can be deadly effects to this practice and how people and babies can die in the midst of this practice. They're not necessarily provided healthcare within these hospitals after they have that initial visitation that resulted in the imprisonment.
I wonder also, I think she was probably leading to this, and you raising the question of audience, I think takes it to.
Okay.
Okay. I was going to say it takes it to another question, which is really about the solution, right? Jim Grant is asking, what are the possibilities for a solution to the problem that are not ransoming individual women or groups of women? Is this about large-scale public exposure of the organization? Who are the organizations practicing imprisonment? Is there some public policy pressure to be brought to bear, enforcement? And I think, you know, are there different aspects of the project, either a report or the multimodal dimensions of it that can produce some of that pressure?
Yeah, I think that I'll give a quick answer and then I'm going to turn that to Carmelle because I feel like she'll have some great thoughts here. I think that there are a lot of options and the options have to be multi-scalar, but it's really important, especially in the case of Haiti, as I mentioned, the problem of exceptionalizing Haiti early on, that we see this that any way that this is discussed cannot put the entire burden of solving the problem on local communities because the problem is systemic and it's widespread. So in as much as I think that local activism is important and having a Haitian-centered report on the practice is critical in order to gain a national sense, the global scale of the problem is at issue, and the way that neoliberal global health financing plays into the practice is critical. So in some ways, there are small scale stopgaps that can be put in place in ways that attention can be turned. And I think all of that's important, and it results in, you know, human beings leaving hospital detention, which is great. But in terms of preventing this going forward, I think there needs to be a much bigger, much broader and more open global discussion on what it means that obstetric care has come to rely on this and the kinds of effects that that has. Now, in terms of it, Carmelle, yon moun mande ki sa ou pense sou solution? Ki sa ou sou yon solution pour problème nan?
Solution problème non c'est faire un genre que pour nous capable camper pratique ça parce que li pas bon pour femme yo. Gen parfois moun yo kon peut aller l'hôpital, yo kon rete la kay yo mouri parce que les à l'hôpital les yo fini, yo pas ka retourner la kay yo kebe yo pour 2 mois, 3 mois parce que yo pas ka payer. Ou connaît ça tout.
Yeah. So Carmelle says there needs to be, the practice just needs to be stopped and banned. And I think that's what she's getting at in Haiti. And that's certainly the report is working towards having a legal procedure that makes it explicitly illegal. Though I would mention that it does break Haitian laws as it exists right now. And not only does it break Haitian laws, but Haiti also has put in its constitution an affirmation of universal health care as a goal. So not only does it break Haitian laws, but in a recent report on hospital detention that the WHO came out with, they mention ways to mitigate the practice, and Haiti has really met all of these ways. It's got an affirmation of universal healthcare rights. It affirms the right of people to movement and freedom from unfair imprisonment. The missing piece is that recommendation, the last recommendation that WHO has, is the importance of international health financing and restructuring the way that it sees for pay or for profit or user fee based medical systems. And what Carmelle also said that's super important is that the reason that this really has to change is because it's part and parcel of this problem that healthcare systems in Haiti have been trying to solve. And I put that because there's a lot of moral investiture in this, but the problem of home birth in Haiti, in which 75% of home births, or 75% of births are home births, and it has the highest maternal and infant mortality in the Western Hemisphere. And this problem of hospital detention is no small part of why there is widespread reluctance to go to hospitals. Carmelle and I have both spoken to mothers who simply refused to go to the hospital out of fear of how long they would be imprisoned. That really impacts at the local level mothers' decisions and willingness to attend hospital birth or to ignore risky symptoms up until a point when it's very late. And a lot of the mothers that we've spoken with in the families have stories of neighbors who the reason that they themselves decided to go to the hospital was because they saw a neighbor make a decision to not go to the hospital, to choose against imprisonment, and they died at home with their baby. So it's really being caught between a rock and a hard place.
I see that we're almost at
Yes.
time. I'm wondering if you have you or Carmelle have some last words you want to leave us with. And again, if you wouldn't mind putting at least the website, right? You can get to the podcast on the website, correct? Yeah, into the chat. Yeah, that would be great.
Okay, great. I'm just going to share it right now. Carmelle, nous pral fini kounye la parce que li déjà 1:05, men li vle konnen eske ou vle rezim, ki sa ou vle denye mot yo, ou vle partager avec moun yo?
Ok, parce que nous avons pile maman que nous aidons sortir dans l'hôpital et avec ce que nous histoire vraiment triste. Si que vous avez des histoires, ça a touché en pile, ou vous voulez faire un bon projet pour nous, comment nous avons des petits bébés maman sortir dans cette situation.
Beautiful, oui. Moi, totalement d'accord. So, Carmelle is pointing back to the need to listen to mothers, that the best way to involve, if you're interested in the problem, is to listen to what mothers have to say, and that we're working on hearing more from them. We have some stories up on birthresistance.com. And we're going, and more mothers are getting involved in families, especially. It's not, I say mothers a lot because they're going through it, but I want to mention that fathers' roles in this have been very important as well. Fathers' commentaries on the practice, brothers, and others who are affected by it, and that there's a need to listen to them. And when you listen to them, something happens, is what Carmelle is saying. It can really change your understanding of the situation.
Great. Well, thank you so much. Thank you, Carmelle, for persevering
Well,
to
yeah.
get with us. And thank you, Alissa, for sharing.
Yeah.
Okay. Before we go, I want to alert you all that our next third Thursday will be on April 15th, and it will be hosted by CAMRA, the Graduate Student Collective for Multimodal Research Arts, and they will be talking about their festival, which will take place the following week, the Screening Scholarship, why am I spacing on the
Screening
acronym?
Scholarship Media.
Media Festival, Screening Scholarship Media Festival. So I hope to see you all there, and thank you for spending some time with us. And again, thank you, Alissa and Carmelle, for talking about your fantastic project. I'm sure that if people want to learn more, they can contact you by email, right? And they can find your email on our website,
They can find it.
cpe10.org. And I think you're putting it in the chat, no?
Yeah, exactly. I accidentally just sent it
Great.
to one person, but we'll send it to everyone. And Carmelle also has. Yeah.
Wonderful.
Thank you guys so much.
Okay.
And have a good Thursday.
Bye, everybody.
Merci en pile, Carmelle. M'apprelo kounye la nan telefon.
Ok, mais d'accord.
Okay.